Okay, thank you, Matthew. So I'm going to be brief because I think you've all had enough. Okay, about 10 years ago I got asked to do a farewell speech for James Isbister and Roger Skerr. And I had a few of these things that came up about James... Oh, sorry, that's bad. Oh, there it is, about James Isbister. So Chris was talking about James being his mentor and et cetera, I think I'm the grandson of that process. And James was very important for me in doing medicine. Many of you may or may not know that I was an intern in haematology in 1990. And I thought this was a pretty interesting place. There was James Isbister, who used to talk a lot about red herrings, what is normal, the viscoreceptor. And Noam Chomsky he introduced me to, started some of my left-leaning politics. And then I went down to the lab and I met Roger Skerr, and he taught me about lots of things: coffee, muffins, Mozart. And also we used to do country clinics together, so we used to go early and have a McMuffin before we got on the plane, and he used to talk about life quite a lot. He's an expert cleaner. Very good. Taught me all about cleanliness, and of course taught me about how to do a cell count and a bone marrow. There are a couple of other important characters at that time. I'm like James Isbister. I kept some of my old ID badges. And I'm very lucky because I actually came into haematology in 1990, and as you can see, the curve took off after that. And so it's just happened to be there at the right time. And I think that's some of those things in life where you're just lucky, aren't you? And there are quite a lot of characters that were in the ward on that time. Nursing, medical, scientific, and as James said, in fact, many of those people are much more important than haematologists, I think, in running of a good unit. And the Australian data reflects the international data, which I showed before. Now, yeah, as I said, North Shore started in 1987, and these three amigos were the ones that ran the show. And Chris Arthur and David Moe were very interesting and also were great mentors to me because when I was an intern for Bob Ravitch, I used to watch these two walk up and down the corridor, and Chris would be loping along with his cardigan and his desert boots. And there'd be this little guy talking up at him the whole time. And of course, they were a great pairing, and as many of you may or may not know, they wrote some really great seminal papers on CML together over the years. I moved to Vincent's after I came back from the UK, and these are some of the characters from that unit: Tony Dodds, Alan Concannon, Kerry Atkinson and Jim Biggs, who of course did a lot of transplantation in Australia. And that was in 1997, as Matthew says, and here's a photo of me and Matthew in 1997. And I don't remember him ever having as deep a voice as he's got now back in 1997. Yes, he looks significantly younger. We both had sideburns. We thought that was pretty cool. But Matthew went the whole way and got the beard as well, and became the true hipster. As also many of you know, St Vincent's and North Shore have this sort of like revolving chair thing happening. And James Isbister, David Moe, Vincent's, then moved to North Shore. David moved back to Vincent's. Dr. Matthew Greenwood, naturopathic physician. Because I can't find any photos of you on the internet. Yes, but I could find that you were a naturopathic physician. Yeah, and Sam Milliken worked at North Shore, went to Vincent's. I worked at North Shore, went to Vincent's. Nada Hamad worked at North Shore, went to Vincent's. And Keith Fay just sits in the middle and does both. Okay, so you have seen, people have stolen my slides, so I'm going to be really quick. I want to talk about collaborations that we've done together over time and what we're going to do in the future. So if you were at HAA last week, the transplant session on the Monday morning, I think 4 of the 5 talks were St Vincent's and North Shore. And this was Amber Bisco's nice work on graft versus host prophylaxis and transplant, and Matthew stole my slide. But I think that's very important because not very many people have actually looked at their own data, and we're doing well, I think, is the answer from that. And that chronic graft versus host helps. There's another study that we're doing together. Elaine Mason, who is a fellow for us, and Catherine Tang, who I think is still here, have looked at AML and MDS allografting prior to starting thymoglobulin. And that's a very nice survival curve for those who had de novo AML having an allograft at either hospital combined, suggesting that we're doing well. And we also looked at an interesting group, and we're going to join with Westmead on this, is to look at people who've had a previous solid tumour or hematological tumour who then got myelodysplasia or AML and had an allograft. And classically, people used to say these people don't do very well, but in fact, in our hands, they do very well and should be offered an allograft. And so we're going to join with Westmead, and the combination will be actually the biggest series ever published. David Kleiman, who's our current fellow, who also worked at North Shore, I think, looked at, he wanted a project this year, and because we've got the registry at St Vincent's, it is very easy for us to do some nice studies, and we just sit around and say, well, what can we talk about? And that TRM data was just fantastic. There's been increasing transplantation in Australia, as you know. We looked at 2,500 transplants. This sort of study could never have been done in the old days in Australia. And 2,500 unrelated transplants we've looked at, because what we were interested was, is it getting safer? Do we want a good news story? Are things getting better? And things are getting better. You know, at each 5-year period since 2001, survival for unrelated transplants has got better. And as you can see from the previous slides, we're doing a lot more of them. At St Vincent's, 2/3 or more of our work is unrelated transplant now. And so we are doing better. And we're doing better because we're making it safer. People are not necessarily, the relapse rate is still a problem, and as Ken said earlier today, relapse is a problem. That's still a problem, and we have to think of ways to reduce that. But we're making it safer, significantly safer. From 2001 to 5, 21% of patients died in the first 100 days. It's now down to 11%. And that's a real success in medicine to show that we can do things safer. And the main reason for that is what we call organ failure has dropped from 44% to 22% of those deaths. And that's unfortunately very vague, but probably reflects better use of antibiotics, better use of antifungals, better recognition of multi-organ failure and other organ systems. And that comes down to better nursing care, better allied health care, and everyone being part of a team, because you can see infection and graft versus host rates haven't actually changed. So we think that's the main reason that things have improved. And if you do a multivariate of that, there are a number of factors, which makes sense. You do someone earlier stage of their disease, they're going to do better, but they're actually going to be less likely to die of complications. You're going to do someone who's better matched, obviously, HLA matched, younger recipient age, better performance status, CMV negative, and particularly if your transplant's been performed in the last 5-year period. Now, another thing that we've done with North Shore, which is really all Ian Kerridge's work, and he's very kindly given me some of his slides, is to look at how are people surviving from transplant. Are they having a better experience? And I might rush through this a bit, but to say that 402 questions were sent out to patients. And there was a large amount of data collected in this, and there are still publications coming out of this Sydney post-BMT study. And they're getting accepted to journals because there's not much around in the medical literature, and this is a credit to the BMT network and to all the centres in Australia. 1,400 patients got sent questionnaires, 66% in the end returned questionnaires, and their median survival was 5 years. So this is a very good snapshot of what is happening out there in the community. We looked at income, education, residency, relationships, things like that. You can see that Westmead had 44%, but if you combine St Vincent's and North Shore, we had 44.2% of those patients. Very good. And they're the standard group of patients. I suppose in the interest of time, I'll move a bit forward on that, except to say that one of the things we looked at was, what about cancers in these patients long time down the track? Skin cancers are a massive problem for us all in Australia, but other tumours do occur as well. And patients actually want to have their model of care at their hospital rather than with their GP, which is I sort of hope that they might reform relationships with their GP, but a lot of them are quite attached, I suspect, particularly to nursing staff, that they want to come back to a hospital that they've been cared for. And also, Ian and his group have shown that people who have a transplant, particularly when they're less than 40, will go back to work. But after that, after the age of 40, they tend not to go back to work. And so I think that's something that requires more investigation. What's that about? Is it people retire early, but are they financially disadvantaged by that? And it probably is it's an important thing for all of us to be looking at in the longer term. In early 2016, Matthew, myself, David Gottlieb, Stephen Larson, Adam Bryant got together and decided to harmonise our protocols so that we'd all do the same thing. Because in New South Wales, I think together we all do 180 allografts or something like that. And that way we could collect data for a year, see how we think we're going, and then start to do trials, which is what we all want to do the randomised trials that Ken talked about. So we decided to do the same conditioning, which you know about. Thymoglobulin was included for the unrelateds, and I'm not going to show the data, but we joined with the Canadians and did a trial on that showing that thymoglobulin reduces graft versus host, acute, which we don't really want, reduces severe chronic GVH, does not affect relapse, does not affect complication rates, and patients' quality of life is significantly better. And so that's now been adopted Sydney-wide, and that's a real advance from the times when we were all working in our own silos, and I think it's a great thing to see. And this is data from the first year just in flu-mel, again showing that we're all doing about the same and we're getting pretty good results. That's all comers there. So what's going to happen in the future? We're going to do trials. We're going to do trials prospectively, and we're going to do them using the bone marrow registry. And a patient of mine had a transplant and was on the thymoglobulin trial, the Canadian thymoglobulin trial, and he raised $300,000 by going to France and riding to the top of Matthew will know, Kumalair or some sort of fancy mountain, and with his mates, and he, with the tight pants on, and went that you wear every Saturday with your coffee. Yes. And he raised $300,000, gave $150,000 to the Leukemia Foundation, and gave $150,000 to me, and we have commenced an online CRF for the registry. And there's Donna and Steve and Leonie sit there in the floor above our outpatients clinic in the Kinghorn Cancer Centre. And what we hope to do is to run trials prospectively using an electronic CRF in the CRF that the centres are going to use anyway to put their data in about their transplants, which is the data that Leonie showed. So it's really only just an extra step to go into the clinical studies portal. And we've managed to include comorbidity index, disease risk index, and also graft versus host. And if you're like me, I'd never know what the name of all these skin conditions are. You can get a photo that shows you exactly what they are. And Donna Aarons did a lot of work on this, and we're very grateful to the Canadians who gave us all those photos and allowed us to use all their slides. And then you can run a report out of this registry and so do trials, and you get a report of all your patients. So this is how we're going to do prospective trials. As much as we like our retrospective data, we want to start moving to prospective data. And we're currently doing a trial with post-transplant cyclophosphamide. Now this is, I think, as Ken said earlier on, one of the big changes in transplantation. Cyclophosphamide, if you look back, I haven't got time to go, but if you look back at all the nice old studies when they used to take skin grafts from siblings, put them on each other, they actually used cyclophosphamide for that. And you can look, they actually did it 3 days after they put the skin graft in. So to stop the immune reactivation. And it's thought, well, we don't know, of course, that it kills off what we call alloreactive cells, but we hope it keeps graft versus leukemia cells, and I'm not sure that's totally clear. Everyone in the world is doing more haplos. And haplos have taken over chords in Australia, on the left, in America on the top right, and in Europe they are rapidly increasing, and they also have shown they've taken over chords. And this has all happened in the last 5 years. And it's all because we're using an old drug that costs nothing, which has massive implications for developing countries starting transplant units, and it switches off graft versus host. And it doesn't affect the stem cell. So we've got a very simple tool, and David mentioned before that we're helping the Sri Lankans. We've told them not to set up an unrelated registry because they're probably not going to use it. All they need to do is tissue type siblings and family members, and they'll find a haplo donor or a matched sibling, and they won't be doing unrelated in the future, almost certainly. So the Baltimore group showed a very simple conditioning regimen with minimal chemotherapy, 1 dose of TBI, and using cyclophosphamide afterwards. And multiple studies since then. I think every time you open a haematology journal, there is something about post-transplant cyclophosphamide haplos being equivalent to siblings or MUDs. But the big problem is these patients, unfortunately, are more likely to relapse, particularly if they've got that high, very high, or even intermediate risk disease. So we thought if we were going to set up a trial using this regimen, which is very safe in that they hardly get any graft versus host, but they have this sort of late relapse, maybe we can change that a bit. And we're using a myeloablative regimen as well. So we're doing this a haplo trial prospectively. So this is really one of the first times that we've tried to do a prospective study in Australia. I'm happy to say that North Shore have joined us, and we're waiting for their first haplo. Bated breath. We're going to incorporate the database, but we're going to try and withdraw their immunosuppression quickly. And with the database, we can say exactly when they stop their immunosuppression, and we can see if that, compared to historical controls, is that going to decrease relapse. And we're also going to do preemptive or prophylactic DLI at day 120, give them T cells from the donor if they haven't developed some chronic graft versus host. So basically, we want that chronic graft versus host to encourage graft versus leukemia. And so we're doing busulfan and fludarabine for myeloablative, and we're using the TBI-based regimen for the reduced intensity. And there's a schema. So we've now accrued 17 patients, 11 from St Vincent's, 3 from Westmead, 3 from Royal Melbourne. We've had 1 transplant-related mortality, which is very good, and none of the patients in the reduced intensity arm have had any transplant-related mortality. So very good data by world standards, and we hope that that study will be finished in probably 18 months. We'll get about 65 patients, and we'll probably stop them. And the point of that is that then we can look at that data and design future trials. And one trial that has already gone to the Future Fund Medical Research Clinical Trials protocol is the CAST study, which is going to compare standard cyclosporin methotrexate against post-transplant cyclophosphamide in patients with a sibling donor. And this is being run out of Melbourne by David Curtis, and we need 134 patients, and should we get the funding for that, we will run that through the registry as well. So I think we're coming now to the time that we are going to do trials and going to answer the questions that we want to answer. So that's been a tour de force. I think that was 60 slides. I'm sorry, it's a bit quick. But I'd like to just, again, reiterate the strong ongoing relationships between St Vincent's and North Shore, and there are excellent outcomes for allograft patients treated at these centres. And the future will be that we'll be doing clinical trials prospectively, online, focused on post-transplant cyclo, reducing toxicity and improving survivorship. There are a lot of people to thank, and sorry this is very medical focused, and I would like to particularly mention a couple of people, particularly the nursing staff, and Yvonne and Cassandra, particularly because you were there when I was an intern and you were very nice to me. Even though I think you were both pregnant at the time, and at St Vincent's, Annabelle, everyone knows that good nursing staff who stay are the foundations of a very good transplant unit, and I'd like to thank them in particular. Okay, thanks.
Right, so Tom's been very generous and just about finished our time. So interesting and productive and insightful day from my perspective. And if I can find my presentation here one more time, here we go. Yes, so here's John one more time with his smiling visage. The theme of the day, or one of the themes of the day, really has been teamwork and how it takes a coordinated and enthusiastic team to try and develop a transplant program that has a successful outcome for patients. And what I was hoping to try and do was finish the day on a look back at successful teams from 1987. Since clearly David, Chris and James were one of those successful teams. And so I went back and I had a look at a successful team from 1987 and was slightly disappointed to find that it was Manly. And not only that, but it was Fatty Borton as captain of the 1987 Premiership winning team with Bob Fulton as coach. And look, in all honesty, despite where we are, I couldn't bring myself to finish the day with Manly as the final slide. So instead I looked for another very successful 1987 team and found Stephen Roach. I'm not sure if anyone can remember Stephen Roach, but he was a Irish hard man of cycling. And in 1987, he managed to do what only Eddie Merckx had done before him, which was win the Tour, the Vuelta, and the Giro all in the same year. And no one else has ever been able to do it since Stephen, despite many people trying. Now, this is an insight, I think, into 80s cycling chic. And you will notice a couple of things here. Firstly, there are aero bars, which of course no one is using. I don't quite understand it myself, but they've all got aero bars, which will just add to the weight of the bicycle and actually not improve their performance. They're all wearing fake denim lycra, which there was a time when, of course, this was extremely popular. And amongst some of my hipster friends, it has made a bit of a comeback. You won't see me today wearing them, but I think at the time they looked pretty good. The other thing, of course, and I think this is an allegory of actually the transplant team members back in 1987, there's actually only one sensible person amongst them, and that's the person wearing the lid. And of course nobody else is wearing a lid, and they all threw caution to the wind, including this man here, who wasn't wearing any sunscreen either. And if you like to use this as a representation for the transplant team at North Shore back in 1987, of course, these people had a very successful year. Stephen unfortunately developed a few knee injuries and had to retire in 1989. But since then, the transplant team at North Shore have gone on to bigger and better things. So with that, I'd like to thank everybody for participating today. It's been an unexpectedly popular discussion. I think I'd like to thank all the speakers who came along. They're offering their insights and their years of experience. And I'd like to thank the patients, of course, as well, who put their trust and confidence in us to try and cure them and look after them. So with that, it's now time to retire for cake and champagne. So is there any questions? John? Well, there is an opportunity for input from patients starting at 6 o'clock.